substance abuse. She's residing in a skilled nursing facility for rehab following, what's an MCA? I didn't write this one. MCA. Motor MVA. Okay, I was going to say motor C accident. Okay, she was in a car wreck. She is expected to be discharged to assisted living once rehab is completed. She's been sober from recreational drugs for over a year. She's taking routine narcotics for pain and is prescribed the medications below, which I'll go over in a second. She has also failed multiple other psychotropics in the past. So she's currently taking, well, she rates her depression as a 2 out of 10 and her anxiety is a 9 out of 10. She's having a hard time sleeping most nights, wakes up a lot. She often requests her Pirin pain and anxiety medications. She's agitated with staff most days and has verbal altercations with her roommate and other residents. She's currently taking Effexor for depression, Wellbutrin for depression, Trazodone for insomnia, Ativan for severe anxiety, Visceral for anxiety, and Seroquel for agitation and insomnia.
So what do you guys notice about this medication profile list for this patient? Yeah, so she's taking the maximum dose of Wellbutrin, which is an SNRI, and then she's taking a pretty high dose of Effexor, which is also an SNRI, and then she's taking Trazodone, which is another antidepressant. So if you see her, she's having difficulty sleeping, and norepinephrine can definitely cause that. She's having anxiety, which norepinephrine can also cause. And then she's not really depressed, so that should be helping with her, right? She's also agitated and has these verbal altercations, and then is requesting on top of that all this additional medication for anxiety. So concerns that we have is the prescription of the medications, polypharmacy, the ineffectiveness of the multiple psychotropics for her anxiety and sleep problems, history of failed treatments, and then drug-drug interactions. And so we did order genetic testing and look at what can we start to reduce for this patient and how can we just change her medication treatment plan to get her stabilized. Typically, genetic testing can be very quick, 3 days, if she was new to the facility, and there was a delay in the results, so I didn't want to continue to prescribe these medications to her, so I decided I was going to take her off of Effexor because I just decided the Effexor was likely the one that wasn't working and she didn't need 2 very high doses of SNRIs. What happened was I came to see her the next time and she was actually more depressed and still she was more depressed, but she was less anxious. And so I was actually able, so here's her results, by the way. It came back that her Effexor was fine. No, where is this?
Yeah.
Okay, I've made that up. I took her off her, oh yes, her Effexor was fine, and her Wellbutrin was fine. So I picked the wrong one, essentially, even though she still had the SNRI, she was overdoing the SNRI. So the fact that her depression worsened, but her anxiety improved, helped show that. So I actually went back up on the Effexor. I had only reduced it by, I think, like two doses at that time, and I took her off the Wellbutrin. And you can wean someone off Wellbutrin a little bit quicker than you can Effexor, but in general, we actually were able to also take her off of her Visceral and her Pirin, Ativan, and the Seroquel. So at the end of it's a couple months that it takes to get these people where they need to be, but at the end of the day, she was just taking the Wellbutrin. So, okay. There's also economic advantages to genetic testing. There's a study that's included in the resources as well, but it was from 2018. It talks about patients who have received pharmacogenomic testing that showed a significant reduction in healthcare utilization. Those who underwent testing on average had 40% fewer all-cause emergency room visits and 58% fewer inpatient all-cause hospitalizations compared to patients who did not have the testing. Overall, 6-month costs were estimated to be about $2,000 lower in the tested group, which indicates a potential cost savings associated with pharmacogenetic testing as well. So reduce healthcare costs, reduce prescription costs, and you could almost argue increase resources as well. Patients who aren't tolerating medications and having to go back and forth between, their provider to get a new prescription or report side effects, going into the emergency room with side effects, are utilizing the healthcare resources that are already understaffed and can help with that. The advantages to a community to use this, really the point here is that they're the same as they are to the patient, right? Improve patient safety, reduce likelihood of side effects, reduce time to medication efficacy, promote medication adherence, reduce polypharmacy, and improve the overall well-being of the patients. So this can all be beneficial to the treatment of patients who have any serious mental illness or issue even with dementia as well, to be able to get them stabilized quicker and to have that improved quality of life. It can also lower some of the burdens that caregivers have with dealing with transitioning from medication to medication